Hi, I'm Dr. Aymeric Becq, former Advanced Endoscopy Fellow at the Beth Israel Deaconess Medical Center, Boston, USA, and currently working in the endoscopy department at Saint-Antoine Hospital, Paris, France.
Hi, I'm Professor Xavier Drey, head of the endoscopy department at Saint-Antoine Hospital, Paris, France. We are here today to talk about your recently published article entitled Prospective Assessment of the Effectiveness of Standard High-Level Disinfection for Echoendoscopes, which was performed at the Beth Israel Center in the Center for Advanced Endoscopy.
Yes, thank you, Xavier.
Aymeric, please tell us a bit about the reasons why the study of endoscope preprocessing is important in this day and age.
Well, in the advanced endoscopy field, there has been, in the recent years, a growing concern about the transmission of multi-drug resistant organisms by endoscopes. Studies have shown that duodenoscopes can act as a reservoir for these organisms, and these endoscopes have been implicated in outbreaks of ERCP-related nosocomial infection by multi-drug resistant organisms.
Yeah. You mentioned studies performed on duodenoscopes. What do we know about this matter regarding echoendoscopes? What specifically prompted this study on these endoscopes?
Well, when we designed the study at first, there was no data regarding the effectiveness of echoendoscope reprocessing. Several studies had shown that in a non-outbreak setting, contamination of linear scopes by multi-drug resistant organisms is a rare, virtually non-described event. Our goal here was to evaluate this rate of contamination in all types of echoendoscopes after a standard high-level disinfection.
And how do the results of your study fit into what is known already?
So in our study, we show 0% of multi-drug resistant contamination and an overall 6% rate of bacterial growth after standard high-level disinfection, which is similar to what is already published. What our results also suggest is that there is no difference of contamination between linear and radial scopes. And finally, the elevator mechanisms for linear echoendoscopes seems to carry a lower risk of contamination as compared to duodenoscopes. The main message here is that in non-outbreak settings, reprocessing seems to ensure a low rate of echoendoscope contamination and an absence of multi-drug resistant organisms.
What do you feel would be the next appropriate step?
I believe there are two issues that need answers here. First is, in a non-outbreak setting, how the standard reprocessing technique is able to avoid contamination of the endoscopes we use in therapeutic endoscopy in patients who are often fragile. Second is, in outbreak settings, where endoscope transmission is suspected, how did it come to happen? Is it because reprocessing was failed, or was it not done adequately? Does it depend on the procedure, thus the type of endoscope we used? I believe larger studies are warranted to ensure that standard reprocessing yields low rates of contamination in the absence of multi-drug resistant organisms. This is the preventive part of the issue and is of paramount importance. Also, I believe tertiary centers should implement a surveillance procedure so as to rapidly identify an outbreak and further our understanding of the origin of these outbreaks, that is, the risk factors. For instance, we believe the higher rate of duodenoscope elevator contamination may be due to the novel design of the duodenoscope that we use, and or a higher likelihood of a damage of the elevator in our duodenoscopes due to the frequency that is increased of tool usage and the stiffness of these tools, and or a higher exposure to infectious environments. There's still much to be done.
Thank you, Aymeric, for this discussion.
Thank you, Xavier.